Hi everyone, thank you for coming down today. Sorry for the technical difficulties. I'm Jing from SGInnovate, and today we are very happy to collaborate with Ocean Protocol for yet another data dialogue. At SGInnovate, we believe Singapore has the capabilities and resources to tackle hard problems from around the world, and part of our efforts includes knowledge-sharing sessions like the one you're here for today. So without further ado, I'll hand over the mic to Daryl from Ocean Protocol to say a few words. Daryl, please.
Okay, great. Thank you so much. Oh, it's very kind. That's actually normally me doing that in the background. Thank you very much for the opportunity to say a few words today. I'm very much looking forward to the panel that we have later. But we thought we'd take the opportunity just to talk you through a use case of an application of IoT put into the health system context, and that application, its generation of asset, how we can actually use blockchain technology to help provide assurance to basically the patient, the hospital, and even the regulator, that such assets are being shared and transferred in a safe, secure, responsible way. And so I make no apologies, because quite often you see slideware. And so we're going to share with you a shitload of code running on screen. And I make no apologies for it, because I don't think we see enough code on screen. And my colleague Bill is basically going to run you through all of that stuff, which is way beyond my pay grade. And I'm just complete fraud, even mentioning the word blockchain, if I'm being perfectly honest with you. But the use case that we're talking about is something that we're doing with Roche Diagnostics. And I just wanted to basically share with you what's basically happening. So we're very familiar with these kind of applications. So Roche has their CocuCheck device, which for somebody who has had heart valve replacement, I'm looking at the colleagues from Roche, you can correct me if I get anything wrong. The medication that you're then taking helps you basically control the thickness of your blood. And so, you have to take great care with respect to the medication, and it's important for you to be regularly checking. Now, in healthcare systems today, what actually happens is that the patient will take the value and then potentially WhatsApp the value to their doctor and wait for them to respond and say, yes, this value is good or not. So when we talk about data sharing, does that sound like a really safe, secure way to share data via WhatsApp? Probably not, but it's the reality of what happens today. So what we wanted to be able to do was we wanted to help address that and actually really think about how we can move beyond devices and think in the context of actually helping the patient better manage their condition. And so you have very simple, the CogIncheck device that you can see on the left, that's speaking via Bluetooth to an app that Connectedlife has developed. So I take my blood reading, it goes to the app, the CogIncheck device, it generates the value, that's then transferred to the app and it's sent up into the Roche cloud. So Roche is the custodian of this data. Sorry, I'm walking in front of everybody. Then in the clouds, there is some processes and transformations on that data. And then on a schedule with the National Heart Center, the data is then shared with the doctors at the National Heart Center at 9 a.m. and 2 p.m. And that's all great. The really interesting thing is, and this is a great piece of automation, and this is ensuring that the data is being captured and shared in a responsible way. But actually, let's just ask the question then, if the regulator would like to then understand, has that data been shared? When was that data registered? Was it shared? What transformation? How would they find out? Now, for organizations like Roche, they may have to develop bespoke systems to provide that information or that capability for the regulator to dive in and get that insight, and that costs money. Likewise, the health system may want to specify, and that costs money and takes time. And when you scale that globally, you could see like an organization like a Roche or a Johnson & Johnson or many of these large pharmaceutical device companies could have hundreds of systems just to be shared, and that is incredibly inefficient. And so I don't want to overuse the word blockchain, but blockchain does basically provide a really useful public utility to make this registration of a data asset, have the conditions of how such an asset can or cannot be shared or transformed. When a transformation does occur, that can be registered on chain, and when data is accessed, that can be changed, and all of that publicly available as a transaction, not exposing the data, just the transaction event to the subject in the app, to the hospital system, and to the healthcare system. And that's what Ocean Protocol is providing as an open source technology to enable such safe, secure data sharing. So this is very simple, but if you speak to any of the doctors in the room, they'll say this is quite transformative, because what is stifling healthcare innovation is that data is incredibly difficult to access and data just can't flow. And these are the things we're trying to address in Ocean Protocol. So it's a real-world application that's working with the National Heart Center with real patients, real pharmacists, and what Bill now is going to do is actually step through how we've developed the code and the actual application. So you're going to see a lot of command line stuff and all the different interactions with the blockchain to actually show how this is all working underneath the hood on a scheduled basis. Is that cool?
Yeah, that's cool. Sounds cool to me. Okay. Oh, hi. Now I'm going to do a non-presentation. I'm going to go to a bash script. Whoa. So I'm not trying to scare you too much, and I'm going to run. I've actually got the demo actually is the problem is going to be right down the bottom, so you can see I run the demo. And just ignore this bit first, because it has to set everything up. And it goes into demo mode. So what I'm doing is I'm running something called Demo Magic, which is fantastic because it pretends to type. So I can look as if I'm really typing really quickly, but I'm not really, I'm just pushing enter. So first of all, I'm going to show you this app I've written called Ocean Drop. And what is Ocean Drop? It's basically a Dropbox for the users. So in this case, it'll be Roche will be actually putting a file into a folder and then run this as a cron job every day or every hour, and then the National Heart Center will have the same application, and they run it every hour and every day, and they'll download the data. But the important thing is that we're involving the blockchain to do this. So the upload process will store the data in the central server, and then register an asset on the blockchain, and then this will then can be brought by the National Health Centre, the actual asset, and then with that link, then go and get the data from storage. So we're not actually putting the data on the blockchain, we're just putting a record on the blockchain so you can see what's happening. How I'm doing the demo, this is a bit more techie, I'm afraid. I'm running something called Barge, which is a Ocean Protocol network stack. So I'll go back to the screen I was just showing you. This is basically a blockchain. It's running on my laptop, and it's just a local blockchain. It's not connecting anywhere. It's just quietly ticking away, going through all the blocks every time. So during the demo, I'll be talking to this section of blockchain and then writing to it and accessing it. So I then go to, yep. So now let's have a look at the actual command. I may have to move that a bit. So this is just it's a simple command line. I got a configuration file and a path and some commands, which are upload, download, status, and watch. So it's very, very, very simple application. And I'll just show you the config file. And here's the config file. So again, it's quite a simple setup. The top one is the most important bit. That's actually where the network is going to be. So if I'm using on a public network, I can set that URL to a public blockchain network. And then my secret is so that I know that both services are talking to each other. So if the publisher creates an entry on the blockchain, I know that when the downloader comes along, it knows it is from the correct person. I don't want anybody pretending to be the publisher. So I won't go through all this, but it's basically, the next bit is really for how I connect to the different services with Ocean Protocol. And the last section down the bottom, I think, is download, which is the accounts. Because when you publish on a network, you have to have an account, and same with the upload as well. You have to have a given account address and password. So then that's it. Now I'm going to see what's on the test folder. Now because I'm running the same code on the same machine, I want to split up the folders. So I've got an upload folder and a download folder. And if I look at the upload folder, I've got 3 files. I've got a README file and a PDF and a CSV file. Is it right to our left? Okay, just on the edge. My pointer. So now I'm going to see the status. So it's going to connect to the blockchain and the services, and it's come back with 3 files need to be uploaded. And it's got 3 files in total there. That's right. So now I'm going to type very quickly and do the actual upload part. And this is where it's actually going to save the data to a central storage area and then register the asset. Oh, it's a bit slow there today. So here's the actual ID, or the asset ID, the DID, you'll see it there. And so what happens is it's registering, so it's storing the data on the server and registering the asset on the blockchain. So then it's done. That's all. It doesn't take that long to do. Now we can check again the status. And it should, oh, there we go. It's up on the end. It says uploaded, downloaded 3 files. Okay. Now, this is where we go to the next section, which is the opposite, the download side. Now, with Ocean Protocol, as a publisher, you have to be available to provide the conditions to sell your assets. So in this situation, I actually have to have a watch process sitting on the blockchain waiting for somebody to go and buy an asset. This is quite useful because I can actually say, I don't want to sell this asset to this person. So I can actually say, I can produce a whitelist to say, I'll only sell this asset to the National Heart Centre, for example, who I know the account address for. So if I now have to go to a separate window, and I've prepared something earlier. I actually have to do up arrow. So now this will actually sit on the blockchain waiting for events, the purchase events to come through, and then we'll process the events. So now I'm going to be the National Heart Centre and actually go to look at the download folder, just to prove you it's empty. It's a bit pointless, it's empty. So now I'm actually going to do the downloading. This is when I say, hello, demo gods. And these are the, I don't think I should go into the agreements, but there's a series of blockchain agreements that have to go through conditions for the actual sale to occur. Once they've occurred, then the money is transferred, or the token is transferred to the publisher. And basically just going through downloading and paying for the different assets on the blockchain. And then eventually it will come to the end. And I think it's one more to do, readme. Oh, no, one more to do. Okay, and it's done. So now I can just quickly have a look at the status again. And I have 3 files in the downloaded, that's it. And I can actually have a look at the files, the folder, and there is the folder. So basically it's quite a simple app, but the point of this is that because I'm working partly with Dex and doing the library behind this, we're also doing a test to see how the library holds together, and as a techie, I really want to try and get the nice, clean, and beautiful looking stuff behind it. So this is if you're a real techie, this is the stuff to have a look, if you want to have a look at the GitHub repos we use to produce this app. Okay? Thank you, Dale. Oh, sorry. Thank you.
So just to be clear, it's kind of interesting. All of the stuff that you've just seen, all the software components that are driving this registration of an asset on-chain, the ability to have a contract concerning the availability and who can consume or have access, and then because just like if we want light, we have to spend a little bit of money on electricity to power that light bulb. If you want to establish the provenance and the trust in the existence, the ownership of an asset, you just have to spend a little bit of money just to write that onto the blockchain and then verify that the asset has been made available, either access to or downloaded. All of the software that enables this is completely open source. It's completely available for anybody to just go and download and construct and use their own systems. And what we see, it's nice to show the stuff happening under the hood because you hear a lot of talk. But this kind of application, there are thousands and thousands and thousands and thousands and thousands of implementations of this type of technology that could basically be utilized, right, for anybody around the world. And what's nice about it, when you talk about the performance issues around blockchain, actually in this context, it's okay. It doesn't have to work within milliseconds, right? The latency and the times, this is absolutely fine. So data sharing, the data economy, is a terrific example of the application of blockchain, tokenization, and smart contracts. That's what we wanted to share, right? But the future of safe, secure, trusted data access in the healthcare industry is happening right now here in Singapore, and Singapore will be a pioneer in this space, and then I'm really grateful for the opportunity to do that. So that's it. Over to the panel, right? Cool. Thank you very much. Thanks.
Thank you so much. We are now going to get into the panel. I think I'll invite my panelists one at a time. I don't know if you've got something on the background, perhaps, with the panelists. Okay. Franz first. Will you grab a seat? Yeah, panelists on the stage. We'll get into introductions with each one of them really shortly. And in the meantime, I'll quickly introduce myself. I'm going to be the facilitator / moderator for this panel this evening. I am Buddha, and I am the founder of Wave Digital. What we do is essentially helping social impact businesses to scale from a business, technology, and skills development perspective. Education, healthcare, disability, and sustainable e-commerce are our fields. Apart from that, I'm part of City AI, which is a not-for-profit community of AI enthusiasts, experts, and entrepreneurs looking at applications of artificial intelligence around the world, of course, healthcare being one of them. Without wasting too much time here, I am going to take my place here. I'm going to have this on with me because I've got a few notes here. This is not me texting. So we'll just get started now. OK. I think we're good to go? Good to start? Yes. So thank you, everyone, for being here. Thank you, panelists. And I think we're going to start with quick introductions. So if you guys could introduce yourself, what you do, and how excited you are to be here. So.
Thank you. Oh, it's off. Test. Okay. Thank you very much. It's a great privilege to be here. I'm very excited. My name is Franz. I'm a medical doctor and also a data scientist at the same time. I'm the chief medical officer of the Singapore-based company Connectedlife, and also I'm part of the board of directors of Ocean Protocol. And we are building, especially in Connectedlife, we are building health AI applications for healthcare professionals and the corresponding patients. And happy to be here.
Hi, my name is Anish. I'm the CEO and co-founder of Curative. We are building AI to make cancer diagnosis fast, cheap, and accurate. And we are essentially working with histopathologists. And we build a technology which will actually help images which are gigabytes in size to be analyzed within minutes. And my background is in mechanobiology, which is a mixture of physics and bio, and that's where I did my PhD in. And I actually started a company in this building on the 3rd floor here. So it is exciting to be here.
Hi, my name is Ian. I am the least qualified amongst all the panelists to be here. I'm an emergency medicine physician. That's my day job, or day, night, and evening, because I work shifts, so I don't know what you call it. But primarily, that's what I do most of the time. Another hat that I wear is with the hospital's group technology office, where we oversee technology for the entire hospital, the National University Hospital system. And we're looking at data infrastructure, where we store data on a single platform. We aggregate the entire data in the whole hospital, which may sound simple, but is actually a huge challenge. And on that same platform, we develop clinical AI tools. So far, we're developing most in-house, but we work together with companies such as Curative as well that have AI solutions. And on the side, I help with startups, primarily medtech startups looking for a value proposition or a connection to physicians or to clinicians for their clinical trials. And in that aspect, together with 2 other colleagues, 2 other doctors, we opened a co-working space out of Alumni Center called Catalyst. It's brand new, so that's part of the reason why I'm very excited to be here. Small pitch, so if you guys have medtech startups or no medtech startups, you can come and look for me or look us up. We're called Catalyst. We're running out of Alumni Center, and we're aiming to bridge the gap between the medtech and device tech startups with clinicians. So very excited to be here because, like the rest of you, I've got a lot to learn from these guys.
Great. The humility and modesty on this panel is fantastic, because when I was reading through their profiles, I was like, everyone's either got a doctor or years of experience, and I'm like, yeah, 2 years doing this, I'll be fine. Okay, so 3 exciting yeses. Thank you, everyone. So if you are excited as well, a round of applause before we get started. Thank you. The topic of today is around looking at data science, potentially a bit of artificial intelligence, a bit of blockchain in terms of the field of healthcare. So I think I'm going to get started a little bit about the company and why you got started. I like to start with motivation. So if you could tell me a little bit about why you do what you do and the challenges that you've faced so far in terms of getting to that point.
Perhaps I'll, with regard specifically to the data aspect of it, first and foremost, as I mentioned earlier, my role is as a clinician, and I believe that, to me, is important because it really, truly sees the challenges which our patients face, and wearing the second hat of technology, how we can bridge that gap to help our patients the best. Now, the challenges which we face primarily in the hospital, outside of the hospital, a lot of it has to do with that aggregation of data. Right now, in any institution around the world, maybe not Estonia, but most places around the world, data is in separate silos. Our billing information is in one silo. Our structured data may be in one silo. Our non-structured data in another silo. Radiology, lab results, everything else are in different silos. And each is owned by a different key opinion leader or a different stakeholder. And to try to bring all of those together, to break down those silos, is truly challenging. Because the other issues we will face is how secure can we keep our data, because this is a very precious data, not just because data is the new oil or is precious, but also because we're dealing with individual patients' data. Many of you belong to some hospital system somewhere, and you wouldn't want that data for the rest of the world. We know what happened recently with one of the hospital clusters, which I won't mention, somewhere in the central part of Singapore, not too far east, but east of us, somewhere in the center. But we know the challenges that they faced, and learning from that episode, we know that we are dealing with very important and precious data which belongs to all of you. So that's probably one of the biggest challenges we face. And another challenge, which I'm sure my two colleagues will share, is adoption by clinicians, which I guess I can leave to them to share more about.
All right. So, I mean, like, if I were to talk about where the company actually started out, I would guess it would start out in the second year of my PhD, where I was sitting there analyzing all this data by hand, and I was like, this is a pain. And so I was like, there must be an easier way to do this. And I'm like, okay, I'm just going to write a program for it. And one thing led to another, and I could now analyze things in about 5 minutes, which would otherwise take me about 3 to 4 weeks of manual work. And I was like, great, I should tell everyone how to do this, but none of my friends cared, because it is a pain in the ass when it comes that you have to actually build all this code, you have to actually write your own solutions. Now, when you translate this exact same kind of analysis into healthcare, specifically into where we are working with, which is in pathology, it actually means that many doctors are doing all this analysis by hand, and this means hours and hours of work for a single patient, which most of which can actually be automated, be much more accurate than what a person can do with their own eyes. And so this understanding that you can actually build computer programs which can do a lot of complex analysis to a point where you can assist a doctor to do their job better. That sort of was the crux of the system that we are building. And what we want to do is to enable hospitals and path labs to give more patients better care faster. So,
great. Thank you.
Thank you. So basically, I give an example of what we do in Connectedlife with Parkinson. So what led us to start this? Actually, back in the days when I was still working as a clinician, I was treating hundreds of Parkinson's patients, and one of the biggest challenges that we were facing as clinicians is that we were completely blind about what symptoms occurred when a patient is at home. And basically, that's really relevant information, because when the patients come to you as a doctor, you as a doctor only get a snapshot of the symptoms. They come there, you interview them, and basically, 30 minutes later, they will leave the practice again. So in the case of PD, where you have the need for really individualized treatment, drug treatment, because patients take their drugs 7-8 times per day, you would actually like to know how they respond to the specific medication, to the specific timing, to the specific dosage, etc. So we came up with the idea back then, it was a couple of years ago, 4 or 5 years ago, that we could actually use motion data coming out of commercial devices to actually track Parkinson's disease motion, basically the motor symptoms. That was the general idea when it all started, and we wanted to use that motion data to actually track those motor symptoms in an objective, continuous, and seamless way. And one of the biggest challenges that we had is that this motion data is basically not really available. Right, it's not a typical data type, especially back in the days. It's not like in radiology, where you have DICOM standards being around for 30, 40 years maybe. It was a completely new data type, and we started to actually collect this data for the first time, and it was a really, really tedious process, because we had to actually label that data with some output that we wanted to model. So we were basically collecting this data from volunteer patients who gave their consent to share that data, and actually following those patients for hours, sometimes for days, to actually get clinical labels by clinical raters. And this process was really, really tedious, but in the end it paid off because like a couple of years later, we are now in a position where we have built models which can actually reliably predict those motor symptoms, and patients can basically stay at home, have a smartwatch, wearing a smartwatch, and we can generate reports which would give information to doctors about motor symptoms for the last 2, 3, 4 weeks. And this really helps to come up with individualized treatment plans and medication schedules, and this is really, really helpful for the patients, but also for the doctors.
Okay, great. So we got motivations, we've got challenges, to a certain degree the solution as well. When you started off, or even now at this point, did you think of metrics of successes, the key metrics that would help you figure out whether what you're trying is in the right direction, whether you need to change? What were those metrics that you set out initially, metrics of success?
So maybe I can take that question. So basically, like in the entrepreneurship world, like in a startup world, we would actually do like a lean approach, right? So especially the medtech, medical world is not really the right place to do such things, but still we did it because we actually collected early feedback from patients, but also from doctors, and this was like the initial validation strategy. It is not like a quantitative metric, but it really helped us a lot to understand the problems and then understand how we can actually address those problems with technology. And because all of this technology is really, really in its early days, we don't have really long-term experience and long-term metrics. But I think for a starting point, this was quite helpful.
Yeah, I mean, like for us, since we build the machine learning tech, there's a lot of internally metrics, things like accuracy, F1 scores, etc., which can be used. But then, as a company, what you want to really measure is are you making an impact? And when you're building something which the doctors are completely new to, the only thing which you can like measure realistically is are they excited by this? And luckily for us, that this was something which was like taken up fairly fast by the doctors that we work with. So now what we actually track is do people like complain every week or not? Because either they'll complain or they'll ignore you. And if there's a week that someone's not complaining, that's a worrying sign. So as of now, that we are in a good place where there are lots of complaints. So yeah, that's a meta metric, I would say.
Okay.
Yeah.
Thanks. So coming from a hospital institution, perhaps our metrics of success may be a little bit different. But similarly, is it all boils down back to the patient. Now, as an example, for the clinical AI tools that we develop, we recently developed a clinical AI tool for appendicitis. That means it's in the background, it's reading the doctor's notes, and it comes up with a diagnosis. And it was as accurate as about 80% of a diagnosis of appendicitis, not as good as the doctor, who was about 88%, but it wasn't too far off. But what was interesting was that the combination of doctor plus AI pushed that whole score up to about 92%. Now, this is for appendicitis, which is fairly simple to diagnose for a trained clinician. Can you imagine the impact that could have, the metrics that, the metric of success then would be that impact that could have if we had other tools for diseases that were more difficult to diagnose? For somebody who comes in with difficulty breathing, it could be the heart, it could be the lung. If we had tools for that, as a pure example, and the tool to augment clinical decision making by doctors, not to replace doctors. I can't lose my job, so well, I hope not to, but if my boss sees me now, he may fire me. But the aim is for these AI tools to augment and improve our decision making and not to replace us. So for us, those are some of the metrics, and that boils back down to the whole concept of improving patients' care.
I was actually going to save that question for a little later, but since you've kind of brought it up, one of the frequently asked questions in usually any emerging field of technology tends to be, is my job in jeopardy? In this case, when it comes to healthcare, with the solutions in either artificial intelligence, either blockchain, is there any truth to that? You've mentioned about augmented workforce almost with AI and doctors working together. But is there any component here where a medical professional should be concerned?
Are there any radiologists or dermatologists in the audience, or pathologists actually? The reality is not yet, and probably not within the next 1 to 2 generations. Why? Because imagine yourself going to see a doctor. Would you rather sit in front of a computer who could tell you your symptoms, or a doctor who actually pays attention to you and sits with you and looks you in the eye to say, tell me your problems? Doctors don't do that now, I agree. But part of the reason, part of the challenge in that is because we are fixated on this computer system, which is why AI can actually help us. We are looking at the computer system of your data, trying to analyze all of your data while we're getting that history from you and inputting that data. Can you imagine if all of that was overtaken in the background, and I could look at you and speak to you, and whatever text to speech to text is working in the background, and at the same time the AI is computing things in the background and just giving me output. I can then make better decisions and spend more of my time with the patient. So,
okay.
Does that help answer your question?
Yes.
So for those who think we don't spend time with the patients, come and look for me. I'll spend some time with you.
I can actually relate to that a little bit because, again, interesting with the healthcare panel, I've kind of had a few healthcare issues myself. And it does make a huge difference when it comes to a doctor who's kind of paying attention to you, even if it's like for a couple of seconds before diving back, versus someone who just comes in and feels like, yeah, you're completely fine. Get out of the way. I want to see the next person. So it does definitely make a big difference there. What about you?
So I essentially agree with him, but where I would like to draw some attention is those aspects and parts of the world where you don't actually have enough like doctors at all. You will often have patients who don't have the right kind of doctor in their area. So like for example, when it comes to like pathologists, like Singapore has 100. Malaysia has 5 times the population, but they have 200. And there are countries in Africa where there's a single pathologist for 5 million people. At this point, you can teach a lot of the lab skills fairly easily, but then the pathology itself has to be taught for about 8 years after you get your medical degree, which means that it's not a skill set which you can grow overnight. So for such a population, not having a doctor is a huge problem, but here I think they would appreciate having a tool which at least does some kind of analysis. So if you're going to ask, like, is it going to replace like doctors? For places which have pathologists, no. But in some places where they're needed, but they just aren't there, at least there'll be some kind of care. So it's not replacing, but it's sort of making one there. So, yeah.
Okay. So augmentation, I think, in 2 different forms in this case. Franz, do you have anything to?
My favorite question. I
yes,
guess.
always.
Like in any panel, like there's no panel where I don't get that question.
Yep.
So basically, I don't think so. So let me give you an example. Like in neurology, like 50 years ago, stroke was diagnosed like just clinically. There was no MRI or CT machine that was used, and neurologists still exist nowadays, right? And they use this technology as augmentation, as tool to make a diagnosis better and faster. But still, like, doctors are needed, and also they will be needed in the future, where AI will play a big role in clinical diagnostics and other fields of healthcare. So I believe that AI can actually support a lot, especially in areas where the demand is much higher than the supply of doctors. So that's a very good example. But also to actually relieve the doctors and, for example, prevent medical errors. Because in diagnostics, due to that supply-demand gap of doctors, often it can happen that something is simply overlooked. So it's a good thing to have an AI support doctors and actually have AI and doctors act as a team. So as you mentioned, I think the combination of both does the trick.
Okay, that's great. And it looks like data and artificial intelligence is here to help us out. With that, there are obviously concerns that people tend to have, and I'm going to try and touch upon 3 of these concerns. There could be more. So I'm going to be looking at privacy, I'm going to be looking at ownership, and I'm going to be looking at biases. So let's begin with privacy. I think with the demo, we kind of touched upon it a little bit in terms of how we could potentially mitigate it. But what are your takes on data privacy, security, especially given a bit of a history in Singapore as well? And what can we do to mitigate that?
Okay, so data privacy is not just a problem for Singapore. As we know, it's a global problem. The challenge is that, okay, so we recently, this weekend, had our annual datathon, where we provide data for clinicians and scientists to get together to work on clinical problems over the weekend. We put our data on the cloud, but we were told that we cannot use hospital data, even if it were anonymized. Part of the reason is that data is still precious data, so we created a synthetic data set for our participants to use, and use some open source data set. But that tells you a little bit about what the current climate is like in Singapore currently. Nobody has an answer just yet, unfortunately, about data protection. There are a lot of MOH and regulatory bodies that are convening to discuss how to manage data privacy. And unfortunately, I don't have an answer for the data privacy part of it, but one potential solution is to move data to the cloud, which is fairly controversial in itself, but that ensures that you have up-to-date security for that data, even if it is our own personal data, up-to-date security for that data and managed by somebody else. So if there is any breach, it's their problem and not ours, I guess. But yeah, so I don't really have an answer truly for data privacy yet. Check this space in about maybe 1 year's time or so, when hopefully we have a little bit more answers. But you wouldn't want any of your data available to anybody else, whether it is as simple as your financial data or whether it is truly your health data. So as a public institution, we know that we have to protect that as well. So from a public institution point of view, we know that your data is precious, and we will do our utmost to protect it, essentially.
Does education of the stakeholders play a role in this? Because again, we are talking about anonymized data, and that still is being perceived as something that is not safe enough. Is there parts of that which could have been mitigated if people were aware of risks?
Partly because, well, if you think about anonymized data, it's very difficult to truly anonymize data, because there's potentially, especially in a place as small as Singapore, there's potentially, if we try to anonymize all healthcare data, and we're using a similar anonymization code for everybody, there is still a potential that somebody knows, this guy went to this clinic on day 1, this clinic on day 2, this clinic on day 3, and figures out the code and can somehow re-identify some of that. So it's not truly anonymized. So that is a challenge that we face. But education plays a big part, especially in big institutions where there are so many potential places where data can be leaked. If we leave a terminal on, for example, and just step out to the washroom, somebody can access that point. So even basic education for the stakeholders and the people in the hospital is important to ensure that your data is protected with us.
Okay. Well, I mean, there are again like two aspects to this. Well, one is that like, yes, like everyone's like data should be like well protected, and then like all those aspects. But with like technology like machine learning, which is primarily like driven by data, I'm personally starting to form the view that data is sort of going to function as like a large scale immune like system for the population of the world. Because if you can share the data, we can kind of build algorithms which can fight against like diseases, which would otherwise be very hard to treat, because I mean, like in some cases you have like 5,000 patients in the world, and they're not always in the same country for the same hospital. So if you could potentially share this data across the world, then you could actually build something which could solve their problems. At the same time, we need to build the right kind of like protocols, I guess, which can enable safe like sharing without having any kind of like deleterious effects on the patients.
Okay,
Yeah.
okay.
So maybe just another comment on that. Like, I'm coming from Germany, and the debate in Germany is quite heated regarding privacy. And what I see is that it's an intangible fear of people. They cannot really give you rational arguments to defend their position. And what I see is that often people mix up privacy and data security. So basically, it's the question with putting data in the cloud, for example. Like, we have had those discussions with many IRB boards, like ethical committees, and they would just tell us, you cannot put the data in the cloud. And then we are just, why? So it's probably the most secure place where you could store the data. And they are like, no, we would rather prefer that you put it on a hard drive and then lock it away. So it's like physical protection. It's like, that's not really secure. I mean, someone could steal the hard drive. And you have those kind of funny discussions. But I truly believe that actually you could solve that concerns or address those concerns with actually technology. And for example, with Ocean Protocol, we are basically developing a technological solution which does many things, but two are very important for the healthcare domain, I believe. The one is like, via the blockchain, you would like log those transactions of data assets, and not only like data assets, but also when like models are called for inference, for example, and you have like full transparency, like who touched data and for which purpose. So that's the one thing. But what you could ultimately do, and this is quite cool, you could actually say, hey, the data does not even leave, as an example, the hospital. The data stays at the hospital, and actually we compute our models just where the data sits. This has two advantages. One is you solve like the data privacy, security, and trust issue, because the data sits where it is. And the second one, especially like in a domain like pathology, where you have like tons of data, it's like terabytes of data, you don't need to move the data. It's just a technological advantage. And I think these are the kind of technology solutions that will actually answer those concerns in an appropriate way.
Okay, great point. I think there was a point around data sharing. I think it's a bit of a common theme. With data sharing, I think one of the concerns that comes up is around ownership of data. So who owns what, what does the patient own, what does the company who's building the app own, what does the hospital own, and who can effectively give permission to make use of that data. So your thoughts on that and potential risks, things that you do to essentially mitigate that.
The institution guy gets to open. Again, I'm not the most qualified for this. But ownership is very interesting. In Singapore right now, ownership kind of belongs, we can call it a shared ownership between patient and doctor. Patient and institution, rather. As a patient, you have a right to the data that we kind of generate from you. But the challenge is, how do you make sense of that data without having gone through a medical degree? Because it can be challenging for somebody who is not trained to know the limits of your reference range, for example, of certain tests. So while we would love to share the data with our patients, we know that the challenge is they may not understand this data or be able to analyze this data in the same way that we can, partly because that's part of why we were trained to do what we do. So ownership primarily right now belongs to the hospitals or institutions currently. An example, recently we had, anyone from Google here, just in case? And you're probably not going to admit it anyway. But so we had Google knocking on our door recently to work together for radiology solution, and they had good technology, and we said, this is great. And we said, yes, okay, let's work together. Then Google says, okay, when can you upload all that data on our cloud? And we said, thank you. as Fran said, data can't leave the hospital. It's right now locked in one of those rooms. But we can't, because we are the custodians of that data on behalf of you guys, essentially. So ownership currently is with us. But there are many moves, especially with blockchain, to bring the ownership back to the patient. Not that they necessarily have to understand what data they have, but they hold it. And they give access rights to whoever physician they visit and decide to consult.
I mean, like, as a company, we mostly like follow whatever are the trends within the world. I mean, like, as of now, we are really working with the hospitals, and we comply to whatever their needs are. That being said, I think there are ways forward where if the data, I mean, like, if the power to share data is given to each and every one of us, then I think there are real ways where we can at least solve how people perceive what is ownership of the data, and how much they actually like value it. Because in the end, when you think about it, a single point of data doesn't mean as much, but it's only like a community shared data where the actual value comes into play. So I mean, like, I'm not like an economist, but I suspect there must be some way where like a model can be worked out that everyone gets the right value for like their personal data.
Would you say the concept of informed consent in this case, when it comes to the patients, what they are sharing versus what they are not sharing, how much in control would you want the patient to be in? How much would you want them to know?
I mean, as of now, I mean, like, even like right now, how much we don't know a lot. I mean, like, the ideal situation is, yes, I mean, everyone should know everything, but then in the end, if I were to tell someone, I don't know, I use like VGG16 to like train like my model on a data, like, how much do you gain by like knowing this? Perhaps it's good enough to know that your data was part of this study, and maybe you're satisfied with that. So if you're going to ask me like what level of like granularity, I don't really know. But yes, I do think like people have a right to know at some level where the data is being used.
Okay. Yeah. Anything to add on this?
Well, I mean, in Germany, at least, we don't have that question, because it's like law to get patients' consent, written informed consent by GDPR. I think it's a good thing. Regarding the level of giving the consent, I think the most important thing here is transparency. I don't know if it makes sense to put like 200 pages of paper to the patient and say that's what potentially we could use this data for. But I think it's being honest and transparent about the positives, negatives, and also the potential impact this data could have when it's processed. So I think it's really important and should not be negotiable.
Okay. The final one is around biases. So I think in most cases we look at data sets. A lot of the initial research that came were from Western countries, and therefore you have a lot of those data sets pertaining to those kind of audiences. So in this case, when we are now looking at Asian or the Asian community and our diagnosis, how easy or difficult is it to extrapolate the data sets that were before? Is there a good way of doing it? What should be done in the future to essentially make this process better?
I'll kick off again. This may be interesting because we may actually get different answers for this. I'm actually keen to hear what my counterparts will say as well. But the purists will say that the data in which you train your clinical AI tool is as good as the data in which you train your clinical AI tool. In other words, if I implement this somewhere else, it may not get the similar results, even if it is in a similar demographic situation, because there are so many other things besides just demographics, which is why there are inherent biases if you use a specific tool trained for your own population in another population, which then means you have to retrain that tool, and that process takes time as well. Plus, you have to ensure that the data in which you're retraining that tool in is cleaned, and that takes another huge amount of time. What that can potentially do, if done well, can actually remove bias. because there is already a huge amount of bias in the doctor's interaction with the patient, because he's using his experience or his eminence or some level of evidence. But your data is looking at huge volumes of evidence which we cannot humanly analyze. So I think if done properly and correctly, it will actually reduce human bias.
Well, like also in terms of data selection, like bias really needs to be considered. Like you just mentioned, like the generalizability problem. Like what we see is like that in many medical imaging papers, which is a very popular domain for application of AI. Like 95% of those papers, I recently read a review on that, have actually been trained on data from just one center. So it can, I mean, it's just stupid to assume that it can be like transferred to another center or even like another country or another population. It's just, I mean, we know for more than a couple of decades that like Asian brains have different properties, like from the anatomical structure than European brains, for example. So if we are looking at radiology scans, then we actually need to include like data from different gender, ethnicity, geographic regions, but also like from different device manufacturers, for example. Like if you train your model on just data from a GE scanner, it will not work on a Siemens, like on data from a Siemens scanner. So you really need to take like all of this into account and consider it during the training and deployment of the models. So that's quite important.
So in our case, it goes beyond that. Sure, I mean like there are these few like center-based like data sets, but there are some diseases that just plain don't exist in the Western world. I mean at least not at the levels that we would need to build good models with. And so we work very hard just to have that amount of data which we can build for the diseases which are much more like prevalent in this part of the world. That being said, having some data somewhere in the world is better than not having anything, because it gives you a sense of what kind of problem you have to solve before you can like solve the exact one that you're after. So it's a matter of being conscious that you are limited by your data, and not being sort of blind to the possibility that, okay, like if I train it here and I take it to, I don't know, Germany, it is going to fail, or then at least it will perform substantially lower than expected. So it is a very real concern.
I mean, from a machine learning perspective, just to add this, I mean, there are ways to account for this. So one would be like a true holdout testing. That's what we, for example, do at Connectedlife, where we test like our models on like different populations, data from different populations, different centers, different countries. Or you could also like take a ready trained model and then use techniques of transfer learning or multitask learning, stuff like that, to actually take a small selection of data from another location or from another demographics or population, and then like do a little bit of retraining of those models. So all of this is possible, but I can just agree with you. You need to be aware of it. Yeah.
And perhaps just to add on, one of the benefits of Singapore is our population is inherently diverse. Just look around at the people in the room. It's incredibly diverse, which is one of the reasons why. On top of that, Singapore is also the gateway to the rest of ASEAN. So with good collaborations in the entire ASEAN, if we have potential good data collection across the entire ASEAN, we have an incredible amount of data, not forgetting that Indonesia is the 4th largest country in the world, which people sometimes tend to forget. To develop tools in Singapore and spread it to the rest of ASEAN, we have an incredible diverse data set.
Great. So we kind of covered the 3 main concerns to a certain degree. What would you say the role of regulatory bodies or governments is in all of this? What is the role that policy plays in all of this? You've got one side, we've got the potential for a lot of benefit coming out of this. For instance, where there are no doctors, you need to have the data to be able to train the systems, to be able to do all of that. Whereas the government comes in to look at the risks and concerns as well, and that could be seen as stifling in some cases. So what is your take on that? We'll probably start with you with the whole GDPR system. And do you see that as a problem? Do you see that as something that is going to actually benefit the population?
So there were many questions, so I have a couple of answers.
Okay.
I think GDPR is a very good thing because it gives like a common ground and common understanding of how things can work. So and it's something that people need to adhere to, which is good, I believe. Like with reference to regulation, I mean, this is just the beginning of AI in healthcare. And when we are talking about, for example, medical device regulation, it's also just the beginning for them. In some or many areas of the world, actually, like also the regulators need to get to know like this whole new field of AI in healthcare. So a couple of weeks back, I had a conversation with a guy from a notified body who is actually like the regulator, and I was explaining him the risks around bias and stuff like that. And it's not a shame for him because how should he know? So it's, I think, like common, like it's a process of understanding for the next couple of years how these new solutions can actually be regulated, because it's just the beginning.
Okay, great.
So like oftentimes like people pitch like regulators against like companies or something like that, which I think is a very like destructive like my mindset to take away, because as like an innovator, you have to I mean, understand that you have been put in this position by the society to build something new. Similarly, the like, regulator has been put into place to make sure that what you build doesn't kill people. And so what you have to do is to actually work with them. I mean, as you said, like, educate them. And almost as a rule, I mean, like, when we first started out, we thought, okay, we should go and ask the regulators what's okay. But I mean, like, regulation always is one step behind innovation, because how can they regulate something which has not been built yet, right? And so because of this, it is sort of the inventor's job to show what is possible, what are the risks, and then how to do this whole thing ethically. And so which is exactly why we also spent like a lot of time working with the regulators, actually teaching them core computer science AI concepts, to make sure that they understand that like when they're analyzing our data, these are the reasons why we don't use accuracy, but I mean maybe we use F-score instead because it's a much better measure of what we are doing. So there's a lot of education involved, but it's definitely not like a like an antagonistic kind of a thing.
Great, good point.
Yeah.
Actually, I don't have much to add because it's quite summed up there. The 2 points which I thought which were brought up, Dr. Franz mentioned also about how this is a very new field. AI is a new field, and how Anish also said that trying to catch up, regulation trying to catch up with innovation. So as Anish mentioned, and what we firmly believe in as well, is right now the responsibility is kind of left to the inventor or the innovator, that the tool you are developing is truly for the interest of the patient and not primarily for financial gain. Again, not saying that doing something for financial gain is wrong, but is the prime reason you're developing this tool because you know that there's a gold mine there, or is it because you really want to help patients? Unfortunately, again, like PDPA issues or patient data protection issues, the jury is still out, something which we'll have to wait another year at least, I would say, before there are regulations for it. Even at the World Health Organization stage level, there may be some guidelines, but no regulations just yet. So for now, it's on us, but hopefully governments can come together worldwide and try to come up with better guidelines and principles for people to create good use of data and AI.
Okay, great. I've got still a few questions left, but I'm mindful of time, so I'm going to open up the floor for questions. Anyone who's got questions, please just raise your hand, and we'll get you there. Great. If you could just introduce yourself a little bit, what you do, and your question. Thank you.
Hi guys, I'm Prabhu. I'm from Ipsen, a pharmaceutical company, and I take care of medical and R&D for Asia. So the question I have is, just looking at your bios, right? Your bios on the website, it seems like all three of you have varying levels of the data science background, right? So, either it's a master's or courses or, courses. So I won't name who's got what, but anyway. So it does seem like you have varying levels of knowledge of maybe programming or data science in coding. So a question for maybe those who are wanting to go into data science and AI, how important is it to have that knowledge of R or Python? Or to understand what we saw earlier in terms of all that text. You see, how important is it in terms of starting a company, in terms of building a company, or is it a matter of just okay, you've got some skills, just bring on people? Is credibility an issue at all, or not? Thanks.
So I think I'll just augment that a little bit because this was in my thing as well. In terms of domain expertise plus combination of technical knowledge, how much of that do you need in order for you to get started? Am I right to say that?
Yeah.
Okay, great.
So maybe I start. So I think we would have been able to really get this started, what we do, without having knowledge from both domains. So I think it's quite important. I think coding and understanding machine learning are two different things. Like coding is just implementation. So it is quite helpful if you understand the basics of machine learning, or if advanced, that's even better, to actually know how you can address specific challenges or questions that you want to answer with a specific technology. So this really helped me a lot to advance our development and set everything up, because usually the data scientist doesn't naturally know what is important. So you as a domain expert should ask the right questions together with the data scientist, and then the data scientist can then start coming up with proposals how to technologically address those questions. And if you have someone who understands both worlds, that will accelerate the process a lot.
So my co-founder actually has done his PhD in machine learning, bachelor's in machine learning. And so because of that, we are able to mix up what we know in the most effective way that we can. Because what our job is essentially to take what is a healthcare problem and translate that into a good, well-defined machine learning problem. And to be able to do that, the role that I used to play was to talk to the doctor, filter out all the information which is not relevant for the problem, then help my co-founder actually build the other thing, and then it's his job to build it in the right way, because machine learning is a whole domain unto itself. So if you're going to ask me, do I need to know R and Python? It's probably good to have some idea of what they are. It is good to know where you can go wrong, and it's good to know what the people you're working with don't know. Because if you can't think ahead of time, oh, this guy is going to miss this, then you are almost guaranteed for a few months they'll be down the wrong path. So I mean, we actually had one incident where one of our engineers was thinking that the nucleus is the cell, but then that was hopefully quickly sorted out. But it's there. I mean, this is not something which you're born with. With something which you learn. So
maybe I also can give an example of that nature. Basically, there was a project of the computer science department at LMU in Munich, and they were working with the radiology department and got CT and MRI images. And basically, it took them 6 months to understand why MRI images can have some artifacts, or why they are not smooth. Before they found out that taking an MRI takes much longer than taking a CT. And of course they couldn't know. How should they? But they did not have that conversation, and also the radiologists didn't know that this was an issue. So like bringing those people together really can save you time and make the whole process more efficient.
I think probably you're just being nice when you say we all have different levels. I have no level of coding, so I don't count. But I think what is important instead of knowing how to code is to know how to understand data, not so much R or Python. I mean, the most coding I did is in Excel. So, but to understand what data can do and the dangers of unclean and improperly used data as well. I think that's important. So if you ever go for a Data 101, these are some of the things that should be talked on. Recently, this weekend, we also hosted a Data 101 for some of our clinicians, and I was there as a facilitator, but I'd never coded in my life, so everything was new to me. And at the end of it, I just looked at the screen and thought to myself, I'm just going to hire a guy to do all of this. but I think knowing a little bit to understand some commonalities in language when you speak to your data scientist, and that ability to collaborate with a data scientist, there is some importance to understanding what data can do for you. But most importantly, I think, is going back to the very basics of understanding the clinical question, or what the problem statement is, or the pain point. It all boils down to a pain point before you want to use the data to solve a problem.
I think I try to say problem, look, understand the possibility and the problem with anything that you do. So I think that helps out quite a bit. And then whether you're a generalist or an expert, generalist usually is the one who connects the dots, works with the teams, understands the why of it all, and then the specialist usually comes in with the domain expertise. But okay,
there's this very nice essay called as The Hedgehog and the Fox. It is really widely applicable. You should read that one if you want to. Why don't they talk about it?
Okay. Got a second question?
Hi, I'm Paula. I'm coming from, I would say, medtech industry. And I have a question for our augmented doctor. Yeah, I wanted to follow on something you mentioned about, you're doing some experiments or some pilots where you're using even doctors' notes as input. And, well, I'm hoping that they have typed them or you have some incredible language processing capabilities. But then the doctor continues to be a tremendous generator of patient data. So with this realization, and I've heard from some other institutions that it's still sometimes a pain point to get doctors to properly capture the data. Is this becoming a topic to sensitize clinicians both at the learning level, as they are, becoming doctors, or as well as practicing?
That's a very good question, actually. Thank you for asking. I hope I don't reveal too much about our healthcare system and chase everyone to overseas healthcare institutions. Thailand's pretty good, by the way. So, yes, we actually train our doctors at the junior intern level. That means they've not graduated from medical school yet, as to proper documentation. For us in Singapore, we're a little bit lucky that okay, I'm not sure whether we are lucky or the patients are lucky, that reimbursement is not based on our clinical notes as it is in the US. So the doctor's notes in the US are of prime importance because the hospitals can't get money if they don't key in their notes properly. Patients don't get reimbursed if they don't key in their notes properly. For us, it's a culture. Again, yes, we do know that some of the junior doctors can potentially take the easy way out and scribble a very short note. I mean, well, type a very short note. But they go through different stages of vetting. So when my junior doctor puts in a note, I actually vet every note that goes in. It's still a manual process. So that's in my own ER department, because when patients come to us for critical illness, I have to ensure the patient is not going to tell the doctor upstairs in the ward what's happened to him. My note has to reflect that. So that data capture becomes really important. But that's one aspect of data. I use the appendicitis tool as an example, but we are going to now expand that to not just look at our free text, unstructured data, but to also look at structured data and radiological imaging and combine all of this together. So you're absolutely right. The training starts from very early on. And we train our medical students in all the institutions in Singapore so far to document properly and the importance of documenting properly. Thank you.
Thanks for the session. My name is Anya. I'm from tech industry. So I have a question, because I see a lot of AI application in the disease diagnosis area. So I want to know how advanced is this technology application in this area, and also what are the biggest challenge of applying AI in disease diagnosis?
I guess I would start by saying that it depends a lot on which disease. That's one thing. And when you say advanced, it could have variously meanings. There's some diseases which have technically been automated for a long, long time. Because if you say measure one single thing and you know, like if a number is above a certain level, that person has the disease. So if you're going to say like how advanced is automation, in some cases very, very advanced. But this is like a very ephemeral kind of a question, because AI by itself is not particularly new. What is new is the hardware that we have, which then enables like a lot of this analysis. So I would say it depends. So yeah, if you better answer, I don't know.
Yeah, maybe like regarding the challenges, I would say like one of the challenge could be that those solutions are very good in areas that are very common. For example, like in the area of imaging, you have solutions for very common diseases like MS or stroke or bleedings. But the problem is that actually you would really need those solutions in areas of rare diseases that could easily be overlooked. But on the other hand, like for those rare diseases, you wouldn't have the training data. So it's like a kind of chicken and egg problem. So this is one of the challenges that we are facing nowadays, I would say.
Okay, I think we'll go one more question. One more question. Yeah.
Hi, my name is Choi, and I'm a data scientist for a neurocognitive testing company. And I want to ask, like, is there a point where you think the AI is going to be so good that doctors become so comfortable that even though the AI is supposed to be assisting them, they just kind of be like, oh, that's what the AI says, and that's what it is. And when another, never mind.
Yeah. Cool. Yeah. Okay. What's your take on that?
I would say doctors are already doing this every time they do a Google search. So yes, that has already happened. But as far as tools are concerned, as long as things have been like vetted properly, it is good for a system which does analysis to disappear into the back end. Because if the doctor is always like conscious, oh yeah, this is like automated output, like I have to be like extra careful with this, I think this will actually hamper how fast they can work. Unlike Google searches, which you just trust. But so, yeah.
What about training in this case? Because again, newer tools are coming in. I'm guessing a big part is to get the medical professionals to understand the limitations of what it can or cannot do, or where they should be applying it. So does that modify the overall training process? How do you incorporate that?
So I mean, the healthcare is not new to new things, because I mean, like AI is just one part of what they do. But I mean, if you look at the kind of antibodies you have, the kind of treatments that you have, things are changing literally every month, not in every year. So they are kind of well equipped to in a way see the future, and the doctors are very like sensitive when it comes to being careful about what the students need to learn. Even at conferences, we have seen very, very senior lady doctors come up to us and say, can you please explain this to me in about like 10 minutes? And so that kind of open like mindset across the board, I mean, not just with young doctors, but even with very experienced ones, helps everyone stay healthier, which is absolutely great for us.
Perfect. Okay. I think we'll have one last question. That's it.
Thank you for letting me have that question. I'm Meghna. I'm part of the Antler cohort. I'm working on developing my own health tech startup. What advice would you all give to a company building a health tech solution or a patient database management solution for countries that do not yet have a solution on hand? Like I was working with some hospitals in India.
Okay, the first thing I can recommend is go to thecatalyst.sg. Once your time with Antler is done, come and get a co-working space with us, and we're the only clinician-driven medtech co-working space in Singapore, possibly in the region.
That's a fantastic plug.
That's all I have to say. No, okay, so so remember at thecatalyst.sg. Okay, so the reality is, I would advise you to look strongly at your competitive landscape. Just because there's none in India yet doesn't mean there are no solutions yet, especially in the health record and data sharing space. The challenge that you will face in entering markets in underserved nations or developing countries or emerging markets is the infrastructure for you to create such a tool, a data storage or data platform is going to be challenging because they may not have that data infrastructure, number one. Number two, the challenges that they may face have got nothing to do with data. The challenges that they face are with how to get healthcare to the community or health equity. So my advice would be to know the ecosystem really well. Are you from India as well? Okay, so you, I mean, you would have lived and breathed some of that as well, especially the Delhi air is great. But knowing the ecosystem is really important, and knowing the existing key players in that ecosystem.
No, I agree.
There's much advice that can be given, but I would keep it very short, like triple the amount of time that you initially had planned for. The whole development process, health tech takes a lot of time.
Okay, great. Thank you everyone for the questions. I'm gonna leave us with one final parting thought around things that excite you about this field so far. Like you've been in the field for a long time, in terms of technology, in terms of where the field is heading towards. Is there anything in particular that is really exciting to you that you're looking forward to happen in the future, probably in the next 1 year, 2 years, probably 5 years? Your metric in that case.
Yeah, from a technology standpoint, I'm really looking actually to continuous learning. So we just, like machine learning just started, and we are actually looking at historical data, but the real game starts now when we deploy the first AI models into clinical practice and actually can make use of all the data that is generated on the way. So that's going to be quite exciting and a game changer.
Great.
For me, it's been like, interesting. I mean, like, even in the few years that we have been around, the attitude of the doctors, like overall, has shifted a lot, where they've gone from being very close-minded and then like defensive to saying, okay, actually now we understand what's most likely going to happen. We want to be a part of this and not work against it. And so that's been immensely exciting. On the technology front, I'm happy to be building what I'm building because like one of my like personal goals is to make people work less on the tedious things in life and much more on the ones that are like creatively exciting. So.
Just to validate that, pathologists are probably the most resistant to change. They are the oldest doctors who sit in front of a microscope and you fall asleep in all of their lectures. So for them to adopt this, you know that other disciplines will adopt it. But in perhaps a parting thought is that with this huge explosion of data that we're having now, to a point where data may rise exponentially every 20-something days. It may double every 20-something days in a number of years. But this huge explosion of data, we can either adopt clinical AI tools, be forced to adopt it, or we can drive the change and be a part of that change. So I would urge all of you to try to be a part of that change. Why I'm confident that in many years' time my job won't be taken away just yet is that artificial intelligence mimics human intelligence. It doesn't mimic human empathy, and the base of patient care is still empathy and love.
Great. On that note, be part of the change. Thank you so much, panelists. It's been fantastic. You've been a fantastic audience as well. Thank you so much. With that, we say thank you.
Thank you, Ian, Anish, and Franz for coming on board as panelists. And I want to have a very big special mention to Buddha. So he has been feeling unwell for the past few days, and he just got discharged from hospital yesterday. But he forgot his rest for this panel discussion. So a big thank you. So I hope you all enjoyed the event. Feedback is always welcome, so just feel free to look for me. To share your feedback. And we'll be sending up a follow-up email as well tomorrow with the video link of this event. So you can actually share with anyone that you think might be interested with this. Yeah?
And I think the panelists will be around for a little bit as well.
Yeah,
so
please feel free to stay and network. Thank you.
Thank you.